Welcome back to The Deep Dive, the show that takes the most critical topics in nursing and, well, extracts those unforgettable insights, giving you a real shortcut to being well-informed.
Yeah, cutting right to the chase.
Exactly. So imagine this scenario. You're on a busy clinical shift, the alarms are maybe softly chiming, but then they start to escalate. You see a patient struggling for every single breath, their chest heaving, and, like right then, every second counts.
That pressure is real.
It is. And as a future nurse, your ability to quickly size up, assess, and manage acute respiratory compromise isn't just important, it's genuinely life-saving.
Absolutely critical skill.
So today we're on a vital mission specifically for you, our dedicated college nursing students. We're going to untangle two major challenges you'll definitely face in clinical practice. Acute respiratory failure, or ARF, and its more severe, often pretty terrifying cousin, acute respiratory distress syndrome, ARDS.
Right, two big ones.
Our goal for this deep dive is really to equip you with the essential knowledge, framed exactly as you'll see it at the bedside, so you can walk into that clinical setting confident and, ready to act.
Yeah, think of this as your practical guide. We'll start with the foundational stuff on ARF, then kind of ease into the complexities of ARDS.
Okay.
We'll simplify the pathophysiology, pinpoint those crucial risk factors and clinical signs you need to spot, talk through diagnostics, and then, importantly, dive deep into the nursing management strategies you'll actually use.
And we'll describe things like tables and care plans verbally, too, right? So you can follow along without needing visuals.
Exactly. We'll paint the picture for you.
Okay, let's unpack this. Let's start with acute respiratory failure, ARF. Now, you said this isn't a disease itself?
That's right. It's more of a symptom, like a critical alarm bell telling us the lungs aren't doing their main job.
Which is gas exchange.
Precisely. It basically means your patient's lungs are either failing to get enough oxygen into the blood or they're failing to get enough carbon dioxide out.
Or sometimes both.
Oh yeah, often it's both. And what's crucial for you as nurses is how we classify ARF, usually based on arterial blood gas results, ABGs.
Okay.
We mainly look at two types. First, there's hypoxemic respiratory failure. You might hear it called oxygenation failure.
Got it. Hypoxemic, low oxygen.
Right. This is when the PaO₂, that's the partial pressure of oxygen in arterial blood, drops below 60 millimeter Hg when the patient's just breathing room air. Normal is usually like 80 to 100, so 60 is a significant dip.
Okay.
Here, the core issue is simply that oxygen isn't getting into the bloodstream effectively.
Makes sense. And the other type?
The other side of the coin is hypercapnic respiratory failure. We often call this ventilatory failure.
Hypercapnic, high CO2.
Exactly. This happens when the PaO₂, the carbon dioxide level, climbs above 50 millimeter Hg, and usually the blood pH dips below 7.35, which means acidosis.
So with hypercapnic failure, the problem isn't getting oxygen in so much as...
Getting carbon dioxide out.
Yeah.
Efficiently expelling it. That's the main struggle.
Right. And is there a difference between acute and chronic ARF?
Oh, definitely. And it's vital to distinguish them because it really impacts the urgency. Acute ARF hits fast, minutes or hours, and demands immediate intervention. It can quickly lead to hemodynamic instability.
Meaning like blood pressure crashing.
Yeah.
Heart struggling.
Yeah, exactly. Whereas chronic ARF develops more slowly over days or maybe weeks. This gives the body a bit of time to compensate, so these patients are generally more stable initially.
And I've heard of acute on chronic failure.
You definitely will see that. A classic example is a patient with long-standing COPD who suddenly gets pneumonia. They have that chronic lung issue simmering, right?
Really?
Then this new infection triggers an acute worsening. That's your acute on chronic picture. It's a real balancing act for the nurse managing them.
Okay. So focusing back on hypoxemic ARF, the low oxygen kind, what's actually going wrong in the lungs? What are the roadblocks?
Good question. The source material breaks it down into four main mechanisms.
Yeah.
The most common one is something called ventilation-perfusion mismatch, or VQ mismatch.
VQ mismatch. Okay.
So normally, air coming in ventilation, the V and blood flow through the lungs perfusion, the Q are pretty well balanced.
Right. They need to meet.
Exactly. But when that balance is off, say in pneumonia where alveoli are filled with secretions, or asthma where airways narrow, or even a pulmonary embolus blocking blood flow, oxygen exchange suffers.
So what's the first thing we do?
Well, the nursing nugget here is that simple oxygen therapy is often your first and most effective step for a VQ mismatch.
Okay, good to know. But then there's shunt. You said that's like an extreme mismatch.
Yeah, exactly. Think of it like blood taking a detour through the lungs but completely bypassing any air. The alveoli might be totally filled with fluid, like in severe pneumonia or pulmonary edema.
So the blood just doesn't get oxygenated at all.
Correct. And the critical distinction for you as a nurse is this. Oxygen therapy alone is usually ineffective for shunt. These patients often need more support, like mechanical ventilation with higher oxygen concentrations, to force that oxygen across.
Okay, that's a key difference. What's the third mechanism?
Third, we have diffusion impairment. This happens when that thin barrier between the air sacs and the blood vessels, the alveolar capillary membrane, gets damaged or thickened.
Like scarred or swollen.
Exactly.
Yeah.
Think pulmonary fibrosis or interstitial lung disease, even ARDS itself. It just slows down how fast oxygen can move across.
Is there a specific sign for this?
Yeah, a clinical sign can be hypoxemia that gets worse with exercise. Because the blood is moving faster, there's even less time for that slow oxygen diffusion to happen.
Interesting. Okay, and the last one.
Finally, there's alveolar hypoventilation, which basically just means not breathing enough.
Just insufficient breathing overall.
Right. While it primarily causes CO2 to build up, which is hypercapnia, it also leads to low oxygen, hypoxemia. Think of things that suppress the drive to breathe, like an opioid overdose, or maybe chest wall problems preventing the lungs from expanding properly.
Gotcha. And it's usually a mix of these.
Almost always. ARF is rarely from just one single cause. Like pneumonia can cause both VQ mismatch and shunt because of the inflammation and fluid buildup. It's complex.
And if we don't fix that hypoxemia quickly, what happens at the cellular level?
Well, it progresses from hypoxemia, low oxygen in the blood, to hypoxia, which is decreased oxygen actually reaching the cells and tissues.
Okay.
Cells then have to switch from their normal, efficient energy production, aerobic metabolism, to a less efficient backup plan, anaerobic metabolism.
Which produces lactic acid, right?
Exactly. That leads to lactic acid buildup, metabolic acidosis, and this throws off a whole bunch of bodily functions. If it goes on too long, it causes cell dysfunction and ultimately cell death. That's why your rapid assessment and intervention are just so critical.
Understood. Okay, let's pivot now to the why behind hypercapnic ARF, the failure to get CO2 out. What are the big categories of causes we need to be thinking about?
We can group them into about 4 main areas. First, central nervous system problems. This is anything that suppresses the brain's basic drive to breathe.
Like what?
Think opioid overdose, a brainstem injury, maybe a severe traumatic brain injury, or even a high spinal cord injury. The signal from the brain telling the body to breathe just isn't getting through properly, or it's weakened.
Okay, CNS problems. What's next?
Then you have neuromuscular problems. These affect the actual muscles of respiration, causing weakness or even paralysis.
So the signal might be okay, but the muscles can't respond.
Precisely. Think conditions like Guillain-Barré syndrome, multiple sclerosis, myasthenia gravis, or exposure to certain toxins that mess with the nerve signals going to those crucial breathing muscles.
Got it. Third category.
The third is chest wall abnormalities. These are structural issues that physically prevent the lungs from expanding normally.
Like?
Things like severe obesity, where the weight restricts chest movement, or a flail chest after trauma, where part of the rib cage is unstable, or even severe kyphoscoliosis, that curvature of the spine, which limits lung volume.
Yeah, makes sense.
Yeah.
And the last one.
And finally, category 4 is problems of the airway and alveoli themselves. Here, it's usually about airflow obstruction and air trapping, making it incredibly hard to exhale CO2 effectively.
So classic examples would be COPD, asthma.
Exactly. Severe exacerbations of COPD, asthma, or cystic fibrosis are prime examples. Interestingly, the body can often tolerate a slow rise in CO2 better than a sudden drop in oxygen, especially if the kidneys have time to compensate by holding onto bicarbonate. But eventually, even that system can get overwhelmed in an acute situation.
Right, so we know the why. How do we actually recognize ARF at the bedside? This seems like where sharp nursing assessment is key.
Absolutely paramount. The signs can really vary depending on how fast it develops, the underlying cause, and how well the patient is compensating initially. That's why frequent, really thorough assessment is a top nursing priority. You can't just assess once and walk away.
Okay, so what are we looking for first?
You know, often one of the earliest indicators of hypoxemic ARF low oxygen is a subtle change in mental status. The brain is incredibly sensitive to lack of oxygen.
So restlessness, confusion, agitation.
Exactly. Those can be early warning signs. On the flip side, for hypercapnic ARF high CO2, the patient might become increasingly sleepy, lethargic, maybe even confused or develop a headache. And of course, prolonged severe hypoxia can cause permanent brain damage. We want to catch it way before that.
We need to think about progression too, right? Early versus late signs.
Definitely. Early signs often include a faster heart rate, tachycardia, for faster breathing, tachypnea, maybe some pallor, and just a mild increase in the effort it takes them to breathe their work of breathing.
And what about cyanosis, the blue lips or fingertips?
Yes. Here's a critical point you must remember. Cyanosis is a late and frankly unreliable sign. It only shows up after there's already a significant amount of deoxygenated hemoglobin floating around. You absolutely cannot wait for a patient to turn blue.
Okay, don't wait for blue. Got it. So observing their work of breathing, WOB, what specifically tells us a lot?
So much. Look at their positioning. Patients in distress often instinctively adopt the tripod position, sitting upright, leaning forward, maybe bracing their arms on a table or their knees.
Why does that help?
It helps maximize chest expansion, using those accessory muscles more effectively. Then, watch their breathing patterns. Are they taking rapid, shallow breaths? Or, and this is a huge red flag, has their breathing shifted from rapid to dangerously slow in a patient who's clearly struggling?
What does that slow rate mean?
It often indicates profound respiratory muscle fatigue. They're tiring out. It can signal impending respiratory arrest.
Wow, okay. What else?
Listen to their speech. Can they speak in full sentences, or are they exhibiting 2-word or 3-word dyspnea, meaning they can only gasp out a couple of words before needing another breath? That tells you how severe it is.
And accessory muscle use.
Yeah, look for that. Are the muscles between their ribs, intercostal or above their collarbones, supraclavicular, sucking in with each breath? Those are retractions. Also observe for pursed lip breathing.
You see that a lot with COPD patients. How does it help?
It's clever, actually. It slows down their respiratory rate, prolongs kind of like PEEP, which helps keep the smaller airways from collapsing during exhalation. It can actually improve their oxygen saturation.
Okay. And in really severe cases?
In very severe distress, you might see paradoxical breathing. That's where the chest and abdomen move in opposite directions during breathing, like the chest wall sucks in during inhalation when it should be moving out. It's a sign of maximal respiratory muscle effort and fatigue.
And auscultation, listening to the lungs.
Of course. You need to listen carefully. Are there fine crackles suggesting fluid like in pulmonary edema? Coarse crackles, maybe from fluid or secretions in the larger airways, like in pneumonia or heart failure. Are breath sounds diminished or even absent in certain areas? That could mean atelectasis, pleural effusion, or just severe hypoventilation.
Okay, so putting all those assessment pieces together gives you the picture. What about diagnostic studies?
Your primary tools are going to be a chest x-ray that can quickly show things like atelectasis, pneumonia, pulmonary edema, and, as we mentioned before, the arterial blood gas analysis, the ABG.
ABGs are key.
Absolutely invaluable. They tell you directly about oxygenation, PaO₂, ventilation, PaO₂, and the patient's acid-base balance, pH bicarb. You'll also rely heavily on continuous pulse oximetry for SpO₂ monitoring, though remember, it's not as precise as an ABG.
Any other tests?
Oh, yeah. Other important ones often include a complete blood count, CBC, to look for infection or anemia, serum electrolytes, maybe a urinalysis, a 12-lead ECG to check the heart. If infection suspected, blood and sputum cultures are essential. And if you suspect a pulmonary embolism is the cause of the ARF, then a CT scan or a VQ lung scan would likely be ordered.
Got it. So let's move into the core of what we do, nursing and interprofessional management of ARF. You said it's a team sport.
Absolutely. Nurses, physicians, respiratory therapists, pharmacists, we all have a crucial role. Your immediate priority as the nurse walking into that room is always going to be assess and secure a patent airway and ensure the patient has adequate breathing and ventilation. ADCs first.
Always ABCs.
Always. And then you're constantly monitoring trends, ABGs, SpO₂, vital signs, and all those subtle clinical changes we just talked about. You have to be alert for even small shifts.
So what are our overall goals for the patient?
The main goals are pretty clear.
Right.
Help the patient independently maintain a patent airway, make sure they're free of dyspnea or their dyspnea is significantly reduced, ensure they can cough effectively and clear secretions, get their ABG values back towards their baseline, and hear breath sounds that are normal or baseline for them.
And prevention is key too, right?
Yeah. Huge. Identifying those at-risk patients early, think post-op neuromuscular disease, existing heart or lung conditions, then actively implementing strategies like preventing atelectasis and pneumonia, through deep breathing, coughing, using that incentive spirometer, getting patients moving early early ambulation, and making sure they're adequately hydrated and nourished. These are fundamental nursing actions that can prevent ARF in the first place.
Okay, so for a patient in acute ARF, what are the core interventions? Let's talk respiratory therapy.
Right. Oxygen therapy is foundational. The main goal is to correct the hypoxemia, but there's a really important nuance here.
Okay.
You need to administer the lowest possible FiO2, that's a fraction of inspired oxygen, to achieve your target PaO₂, which is generally greater than 60 millimeter Hg, and an SaO2 or SpO2, usually greater than 90%. We don't want to overdo it.
Why not? Is there a risk with too much oxygen?
Yes, absolutely. This is a safety alert. Be aware of oxygen toxicity. Giving FiO2 greater than 60% for more than 48 hours can actually damage the lungs. And another thing is absorption atelectasis HiO2 can wash out nitrogen in the alveoli, making them prone to collapse.
Ah, okay. And what about patients with chronic high CO2, like copy DIRS?
Good point. Special caution there. For patients with known chronic hypercapnia, remember their respiratory drive might be blunted by high oxygen levels. Their bodies are used to high CO2 and sometimes low O2 as their main drive to breathe.
So you start low.
Exactly. For these patients, you typically start with low flow O2, maybe 1 to 2 liters per minute via nasal cannula, or perhaps a 24% to 28% Venturi mask, and then you titrate very carefully based on their ABGs and clinical status.
Okay. Besides oxygen, what about secretions? They can be a big problem.
Huge problem. Mobilizing secretions is another cornerstone of respiratory care. Positioning is key. Just elevating the head of the bed to at least 30 degrees helps a lot with lung expansion and drainage.
And that good lung down thing.
Right. For a patient with a significant one-sided lung problem, like right-sided pneumonia, positioning them on their left side, the good lung down, can improve VQ matching. Gravity helps send more blood flow to the healthy, better ventilated lung, and it can also help drain secretions from the affected side.
Clever. What about coughing?
We need to help them cough effectively. There are techniques like augmented coughing or quad coughing, where you apply gentle hand pressure to their abdomen during exhalation to assist the cough. There's also huff coughing, short, sharp exhales like huffing onto glass, which helps move mucus up without closing the glottis.
Any other methods for secretions?
Yep. Chest physiotherapy, CPT, which includes postural drainage, percussion, and vibration, can be useful, although there are contraindications. Suctioning is often necessary, but you have to be careful, especially with the gag reflex and potential for hypoxia. Humidification via aerosols helps thin secretions. And ensuring adequate hydration, usually aiming for 2 to 3 liters of fluid a day, unless there's a reason not to, like heart failure is really important. 5E fluids might be needed too.
Okay. What if oxygen and secretion management aren't enough?
Then you might need to move to positive pressure ventilation or PTV. This can be non-invasive initially.
Like BiPAP or CPAP?
Exactly. Non-invasive positive pressure ventilation, NIPPV, like BiPAP, which provides 2 pressure levels, higher on inhale, lower on exhale, or CPAP, constant pressure, can be great. They're most useful for patients who are awake, alert, have stable vital signs, maybe dealing with a COPD exacerbation or cardiogenic pulmonary edema.
But if that fails, or they're really severe,
then intubation with mechanical ventilation becomes necessary. That's a more definitive way to support breathing and oxygenation in severe ARF.
let's touch on drug therapy. What meds are commonly used?
It's really tailored to the underlying cause. If there's bronchospasm, you'll use bronchodilators like albuterol, but you need to monitor for side effects like tachycardia and hypertension.
Okay.
If inflammation is a big component, corticosteroids like IV methylprednisolone might be given. But another drug alert here: monitor potassium levels, watch for hyperglycemia, and be aware of adrenal insufficiency with prolonged use.
What about fluid overload, like in heart failure?
Then you'd expect diuretics like furosemide, maybe morphine or nitroglycerin to reduce preload and afterload. But again, monitor heart rate and blood pressure closely. If it's an infection causing the ARF, then appropriate antibiotics are crucial.
And what about managing anxiety or pain, which must be high in these patients?
Definitely. Benzodiazepines like lorazepam or opioids like morphine or fentanyl are often used for anxiety, pain, and restlessness, especially if the patient is on a ventilator. But here's a massive safety alert. Always assess and treat the underlying cause first, particularly hypoxemia. Don't just sedate a hypoxic patient. Sedation can help comfort and ventilator synchrony, but it doesn't fix the root problem.
Good point. Treat the cause, not just the symptom. And nutrition.
Absolutely vital. Critically ill patients are in a hypermetabolic state. Their bodies are burning through energy. Early nutrition therapy, ideally enteral nutrition, tube feeding, started within 24 to 48 hours, is crucial to preserve muscle mass, support immune function, and prevent delayed recovery.
And we should remember older adults are at higher risk for ARF.
Yes, definitely. Factors like reduced ventilatory capacity, decreased lung elasticity, weaker respiratory muscles, and a somewhat slower response to changes in PaO₂ and PaCO₂ all put older adults at increased risk. Your assessments need to be particularly sharp with them.
Okay, that gives us a really solid foundation for ARF. But now let's shift gears to where things get, well, even more challenging. Acute respiratory distress syndrome, or ARDS.
Right. ARDS. This is a sudden, progressive, and really severe form of ARF. The defining feature is that the alveolar capillary membrane, that thin barrier, becomes severely damaged and highly permeable to fluid.
So the lungs basically fill up with fluid.
In a way, yes. It's not exactly like typical pulmonary edema from heart failure, though. This is inflammatory fluid flooding the air sacs due to widespread lung injury. It's a common and very serious condition in the ICU, and unfortunately, it still carries a significant mortality rate, around 35% or sometimes higher.
What causes ARDS? Is it the same as ARF?
There's overlap, but ARDS has some specific triggers. The most common cause, interestingly, is often sepsis and the resulting multi-system organ dysfunction syndrome, or MODS.
So an infection somewhere else in the body can lead to ARDS.
Absolutely. That's considered an indirect lung injury. Other indirect causes include massive trauma, shock states, acute pancreatitis, even multiple blood transfusions leading to TRA transfusion-related acute lung injury.
And direct lung injury.
That happens when the insult hits the lungs directly. Things like aspiration of stomach contents, severe bacterial or viral pneumonia, chest trauma, inhaling toxic substances, near drowning, even oxygen toxicity itself.
Okay, so what's happening pathophysiologically in ARDS? You mentioned phases.
Yes, understanding the 3 phases helps you anticipate what's happening. The first is the injury or exudative phase. This usually kicks in within 24 to 72 hours after the initial insult, and it can last for about a week to 10 days.
What happens here?
This is where the initial injury triggers a massive inflammatory response in the lungs. Those capillaries become leaky, and fluid, protein, and inflammatory cells pour out into the interstitial space and then flood the alveoli, the air sacs.
So edema in the alveoli.
Exactly. Interstitial and alveolar edema. This results in severe VQ mismatch and significant shunt because blood is flowing past fluid-filled or collapsed alveoli. Oxygen just can't get across.
And the lung cells themselves.
They get damaged too. Critical type I cells, which handle gas exchange, and type II cells, which produce surfactant, that substance that keeps alveoli from collapsing, are injured. Less surfactant means widespread alveolar collapse, or atelectasis.
Which makes the lungs stiff.
Very stiff.
Yeah.
Decreased lung compliance. Plus, debris and proteins form something called hyaline membranes along the alveolar walls, further thickening that barrier and worsening gas exchange.
And this leads to
the hallmark sign of ARDS, refractory hypoxemia.
Explain that again. Refractory hypoxemia.
It means the patient's hypoxemia, their low blood oxygen level, doesn't improve significantly even when you give them very high concentrations of supplemental oxygen, like 100% FiO2. The damage is so severe, the oxygen just can't get into the blood effectively no matter how much you supply.
Wow. Okay, that's the first phase. What's next?
Next comes the reparative or proliferative phase. This usually starts about 1 to 2 weeks after the initial injury. Here, the body tries to repair itself, but it's often disorganized.
How so?
Well, there's a continued influx of inflammatory cells, but also fibroblasts start laying down collagen. This can lead to interstitial fibrosis scarring and further thickening of the lung tissue. Hypoxemia often persists or may even worsen during this phase. You can also see increased pulmonary vascular resistance and pulmonary hypertension starting to develop. Some patients' lungs might start to heal here, but for others, this phase sets the stage for chronic problems.
In the third phase?
The third phase is the fibrotic or fibroproliferative phase. Thankfully, not all patients progress this far, but those who do generally have a poorer prognosis. This phase can start as early as 24 hours, but it's more about the long-term outcome.
What defines this phase?
Essentially, diffuse scarring and fibrosis throughout the lungs. The normal lung architecture gets destroyed and replaced by dense fibrous tissue. This leads to severely decreased lung compliance, very stiff lungs, and a permanently reduced surface area for gas exchange. These patients often have persistent severe hypoxemia and significant pulmonary hypertension.
Okay, those phases really map out the progression. How does ARDS actually look clinically? Does it start dramatically?
Often, no. That's the tricky part. Initially, in those first 24 to 72 hours, the signs can be quite subtle. Maybe just mild shortness of breath, dyspnea, a slightly increased breathing rate, tachypnea, maybe a cough, some restlessness.
So easy to miss.
Potentially, if you're not looking closely or don't have a high index of suspicion based on their risk factors. Auscultation might even be normal initially, or maybe just some fine crackles. Early ABGs might only show mild hypoxemia, maybe a respiratory alkalosis because they're breathing fast trying to compensate. Even the chest x-ray can look surprisingly normal or show only minimal scattered infiltrates early on.
But then it changes.
Oh, yes. As ARDS evolves, the symptoms worsen dramatically, usually over hours to days. You'll see increased work of breathing become obvious, tachypnea, retractions, sweating, diaphoresis, tachycardia. Their mental status might decline further. Cyanosis and pallor can become evident. On auscultation, you'll likely hear diffuse crackles, sometimes coarse crackles as fluid accumulates.
And the chest x-ray.
After about 72 hours, the chest x-ray typically shows those characteristic diffuse, extensive, bilateral, interstitial, and alveolar infiltrates. It's often described as a whiteout or having a ground glass appearance because the lungs are so filled with fluid and collapsed areas.
And the ABGs will confirm.
They'll confirm worsening oxygenation with that refractory hypoxemia as the key finding. As the patient tires or the disease progresses, you might also see the PaCO₂ start to rise, indicating hypercapnia and severe respiratory muscle fatigue, which is a very ominous sign.
You mentioned a way to quantify severity, the PF ratio.
Yes, the PaO₂ FiO2 ratio, often just called the PF ratio. This is crucial for diagnosing and staging ARDS severity. You simply divide the patient's arterial PaO₂ by the FiO2 they're receiving, expressed as a decimal.
Okay, so how do we interpret it?
A normal PF ratio is generally considered greater than 400. For ARDS, mild ARDS, PF ratio is between 201 and 300. Moderate ARDS, PF ratio is between 101 and 200. Severe ARDS, PF ratio is 100 or less.
Let's do the example again. A 26-year-old, FiO2 of 0.90, PaO2 of 83.
Right, so you calculate 83 divided by 0.90. That gives you roughly 92.2.
Which is less than 100.
Exactly. That immediately tells you this patient has severe ARDS. It objectively demonstrates that critical refractory hypoxemia, despite getting 90% oxygen, her blood oxygen level is still dangerously low. This calculation is something you'll commonly see used in the ICU to classify patients and guide treatment intensity.
Makes sense. It's a useful tool. Now, ARDS sounds like it affects more than just the lungs. What are the common complications?
You're right. It's often a systemic problem. The kidneys, liver, heart, brain, they can all be affected, partly due to the underlying cause, like sepsis, and partly due to the consequences of severe hypoxia and inflammation. MODS, multisystem organ dysfunction syndrome, often driven by sepsis, is actually the leading cause of death in ARDS patients, not just respiratory failure itself.
Wow. Okay. What about lung-specific complications?
A big one is ventilator-associated pneumonia, VAP. Being on a ventilator bypasses natural airway defenses, making patients highly susceptible to lung infections.
So prevention is key.
Absolutely critical. That's why implementing a ventilator bundle protocol is standard practice in ICUs. These bundles usually include things like meticulous hand washing, keeping the head of the bed elevated, usually 30–45 degrees, daily assessments of readiness to wean off the ventilator or extubate, prophylaxis for stomach ulcers and blood clots, VTE, and regular, thorough oral care, often using chlorhexidine rinse.
Okay, the VAP bundle. What else?
Another risk, especially with mechanical ventilation, is barotrauma or volutrauma.
Damage from pressure or volume.
Exactly. The high pressures or large volumes needed to ventilate stiff ARDS lungs can overdistend and rupture fragile alveoli. This can lead to problems like pneumothorax, collapsed lung, or subcutaneous emphysema, air leaking into tissues under the skin. We try to prevent this using specific ventilator strategies, which we'll talk about.
Got it. Other complications.
GI stress ulcers are common, likely due to reduced blood flow to the gut during critical illness. We usually manage this prophylactically with anti-ulcer medications like proton pump inhibitors or H2 blockers. And importantly, starting early enteral nutrition helps protect the gut lining.
And blood clots.
Yes, venous thromboembolism, VTE, DVTs, and PEs are a significant risk because these patients are typically immobile for long periods. So VTE prophylaxis is essential, using things like sequential compression devices, SEDs, anticoagulant medications like heparin or enoxaparin, and trying to get them moving as soon as it's safe.
Kidneys too.
Acute kidney injury, AKI, is unfortunately common in ARDS patients. It can be due to decreased kidney perfusion from shock or low cardiac output, the systemic inflammation, hypoxemia itself, or sometimes nephrotoxic drugs used to treat infections or manage hemodynamics. These patients often require dialysis, frequently continuous renal replacement therapy, CRRT, because they're too unstable for traditional hemodialysis.
And the psychological impact. This sounds incredibly traumatic for patients.
It absolutely is. Surviving ARDS and a prolonged ICU stay often leaves patients with significant long-term psychological issues. Anxiety, depression, memory problems, nightmares, and post-traumatic stress disorder, PTSD, are sadly quite common, sometimes persisting for years after they leave the hospital. This is an aspect of care we really need to be mindful of, both during and after their ICU stay.
That's so important to remember the whole person long after the acute phase. Okay, let's dive into the advanced nursing and interprofessional management of ARDS. How does it build on ARF care?
It definitely builds on the principles of ARF management, but with additional, more intensive ARDS-specific interventions almost always happening in the ICU setting.
So oxygen. Still key, but maybe different.
Still absolutely key, but often high-flow oxygen via mask or cannula is only temporary or insufficient due to that refractory hypoxemia. For moderate to severe ARDS, mechanical ventilation is typically required pretty early on. And we often need to use high FiO2, sometimes 70% or even higher, at least initially, trying to maintain a target PaO₂ between 55 and 80 millimeter Hg, and in SpO2 usually between 88% and 95%.
Okay, mechanical ventilation is standard. Are there specific ways we ventilate ARDS patients?
Yes, this is critical. The standard of care now is low tidal volume, VT ventilation.
Low volume, why?
Because ARDS lungs are stiff, non-compliant, and easily injured. Delivering large breaths, high tidal volumes, like we might use in healthier lungs, can stretch and tear those fragile alveoli, causing that volutrauma and barotrauma we talked about. So we use smaller breaths, typically calculated based on ideal body weight, usually around 4 to 8 milliliter per kilogram.
But if you use smaller breaths, won't CO2 build up?
It often does, and that leads to another important concept, permissive hypercapnia. Because we're prioritizing lung protection with low tidal volumes, we sometimes accept a higher level of CO2 in the blood than normal.
You let the CO2 rise.
To a certain extent, yes. We might allow the PaCO₂ to rise, sometimes up to 60 millimeter Hg or even a bit higher, as long as the patient's blood pH stays within an acceptable range, usually between about 7.3 and 7.45, and the rise in CO2 is gradual. It's a trade-off accepting mild acidosis to prevent further lung injury.
Are there patients you wouldn't do this with?
Absolutely. Permissive hypercapnia is generally contraindicated in patients with traumatic brain injury or increased intracranial pressure because high CO2 can worsen brain swelling. Also, typically avoided in pregnancy. And it requires the patient to be well sedated and comfortable, usually with continuous IV analgesia and sedation.
Okay. What about PEEP? Positive end expiratory pressure.
PEEP is another cornerstone of ARDS ventilation. It applies pressure at the end of exhalation to help keep alveoli open, recruiting collapsed alveoli, and improving oxygenation by increasing the surface area for gas exchange.
Do ARDS patients need more PEEP?
Often, yes. While we use low PEEP in many ventilated patients, ARDS patients frequently require higher levels, sometimes 10, 15, even 20 centimeter H2O or more, to overcome the atelectasis and improve oxygenation.
Are there risks with high PEEP?
Yes. High levels of PEEP can impede venous return to the heart, potentially decreasing cardiac output and blood pressure. It also increases the risk of barotrauma and volutrauma. So, finding the optimal level of PEEP is a balancing act, constantly weighing the benefits for oxygenation against the potential hemodynamic and lung injury risks. We monitor hemodynamics very closely when adjusting PEEP.
Okay. Now what about that striking intervention? Prone positioning, turning patients onto their stomachs.
Yes, proning. This has become a key strategy, especially for patients with severe ARDS and refractory hypoxemia that isn't responding well to high FiO2 and PEEP.
How exactly does turning them onto their stomach help?
It works primarily by improving VQ matching. When a patient is lying on their back, supine, the weight of the heart and abdominal contents compresses the lung tissue in the back, posterior regions, leading to atelectasis there. Blood flow, however, is still greatest in those dependent posterior areas due to gravity.
So blood flows where the air isn't getting.
Exactly, classic shunt. When you turn them prone onto their stomach, gravity helps shift perfusion towards the now better aerated anterior lung regions. It also helps recruit or open up those previously collapsed posterior alveoli by relieving the compression. The overall effect is often a dramatic improvement in oxygenation.
It sounds complicated to do.
It is. Proning requires a coordinated team effort, typically an intensivist physician, a respiratory therapist, and at least 3, often 4, nurses. Meticulous planning is needed to protect the airway, especially the endotracheal tube, IV lines, and monitoring devices. You have to be vigilant for hemodynamic instability during the turn, and often patients produce more secretions when prone, requiring more frequent suctioning.
How long do they stay prone?
Protocols vary, but typically patients are proned early in the course of severe ARDS and may remain prone for extended periods, often up to 16 hours per day, before being turned back supine for a period. Some units use specialized beds or devices to facilitate proning. There are also related therapies like continuous lateral rotation therapy, CLRT, using special beds.
Okay. And if even proning isn't enough, is there anything else?
In the most severe, life-threatening cases of ARDS where conventional ventilation fails, a highly specialized therapy called extracorporeal membrane oxygenation, or ECMO, might be considered.
ECMO, what's that?
Think of it like heart-lung bypass or dialysis for the lungs. Large catheters are placed, blood is removed from the body, pumped through an artificial lung oxygenator that adds oxygen and removes CO2, and then returned to the body. It essentially takes over the work of the lungs, allowing them to rest and heal.
That sounds incredibly complex.
It is. ECMO is only available at specialized centers with highly trained teams, physicians, nurses, perfusionists, RTs. It's a high-risk, resource-intensive therapy reserved for patients who are likely to die without it.
Wow. Okay, beyond the ventilator and positioning, what about supportive care in ARDS?
Supportive care is absolutely vital. Continuous analgesia and sedation are usually essential. Patients with ARDS are critically ill, uncomfortable, anxious, and need sedation to tolerate mechanical ventilation, especially with strategies like low tidal volumes or proning.
What if they're still fighting the ventilator despite sedation?
If patients remain asynchronous with the ventilator, bucking, coughing, straining, despite adequate analgesia and sedation, then neuromuscular blocking agents, NMBAs, paralytics, may be used for a period. These drugs paralyze the respiratory muscles, allowing the ventilator to fully control breathing and minimizing oxygen consumption.
Paralytics sound scary.
They are, and they come with risks like prolonged muscle weakness. And here's another absolutely critical safety alert. You must always administer concurrent analgesia and sedation when a patient is receiving an NBA. Being paralyzed but awake, aware, and potentially in pain is an incredibly terrifying and inhumane experience that must be prevented at all costs. We monitor the level of paralysis using a peripheral nerve stimulator, Train-of-4 monitoring.
Okay, always sedate if you paralyze. Got it. What else for supportive care?
We need to promote tissue perfusion. Continuous hemodynamic monitoring is standard ECG, invasive arterial blood pressure, continuous PaO₂, sometimes central venous pressure, or even pulmonary artery catheter monitoring. If cardiac output is low, we might give IV fluids cautiously or use vasoactive drugs, vasopressors like norepinephrine or inotropes like dobutamine, to support blood pressure and heart function.
And fluid balance. You mentioned keeping them dry.
Yes, maintaining fluid balance is really tricky in ARDS because those leaky capillaries mean fluids can easily shift into the lungs. While we need to ensure adequate organ perfusion, aggressive IV fluid resuscitation can often worsen lung edema, so the goal is often to keep patients slightly dry or euvolemic once the initial shock phase is managed. Diuretics might be used, and as mentioned, CRT can be very helpful for precise fluid removal in patients with AKI or significant fluid overload.
And nutrition remains crucial.
Absolutely. Just like with ARF, these patients are hypermetabolic. Early enteral nutrition within 24 to 48 hours remains a priority to support their metabolic needs, maintain gut integrity, and prevent muscle wasting.
So the overall evaluation goals for ARDS care.
The ultimate goals are to see the patient maintain adequate oxygenation and ventilation with decreasing levels of oxygen support in ventilator settings, achieve and maintain hemodynamic stability without vasoactive drugs as possible, and recover free from major complications like VAP, barotrauma, or AKI. It's a long road for many of them.
Wow, what a really comprehensive deep dive we've taken. We've thoroughly unpacked acute respiratory failure and then drilled down into its more severe form, acute respiratory distress syndrome.
Yeah, covered a lot of ground.
You definitely have a much more robust toolkit now. From distinguishing hypoxemic versus hypercapnic ARF, really understanding that critical concept of refractory hypoxemia in ARDS, to knowing the rationale behind lung protective strategies like low tidal volume ventilation and the huge team effort involved in prone positioning.
Hopefully it helps you feel more prepared when you encounter these situations.
Absolutely. And as you move forward in your nursing career, here's something to think about. The respiratory system is so foundational to life, right?
Yeah.
Yet so many different things can compromise it, often incredibly rapidly.
Yeah.
How does that constant interplay, that potential for sudden deterioration, challenge you as a future nurse? How does it push you to not just react, but to actively anticipate, to intervene precisely, and to advocate effectively, always with compassion?
Mm-hmm.
And think beyond the ICU stay too. What might the long-term journey look like for these patients who survive ARDS? How can our nursing care extend beyond just the acute interventions to truly support their physical and psychological recovery and ultimately their quality of life for months, maybe even years to come?
Those are really powerful questions, ones that thinking about will truly shape your practice and I think make you an extraordinary nurse. We really hope this deep dive has given you a solid foundation for understanding these complex, often life-threatening conditions.
Thank you so much for joining us on this essential deep dive. Stay curious, keep learning, ask questions, and as always, thank you from the Last Minute Lecture team.